Hi, this is Brian Kim. I'm going to share with you case number 263 in the best way to do cataract surgery series. And the title of this series is not to suggest this is the best and only way, but to get you to think critically of your technique so that you can provide the very best for your patient. And so this is a deep set orbit, and you can see the standard Lieberman is so big in this patient's eye. You don't get any exposure of the eye superior and inferiorly, which is very important when you're doing temporal cataract surgery. So you're going to see the use of the narrow wire speculum, which really gives excellent exposure, much better exposure than the standard Lieberman. This patient also has a Bell's reflex. And you're going to see how I deal with pooling in this deep set eye using the Tegaderm hack. So you can see this patient has a strong Bell's reflex. I'm using the cotton tip to help control the eye, but look at the exposure of the eye superiorly and inferiorly. Not a lot of room. And so I'm going to switch from the standard Lieberman speculum, which is really too big in some patients, and I'm switching to this smaller narrow wire speculum in this deep orbit. And look at the superior and inferior exposure now. You cannot overstate how important that is and how much better this is than the standard Lieberman. So I'm using the cotton tip to steady the eye, and then using a corneal marker, which will help me to center and size the rexus. This is my paracentesis incision. You can see the patient has a strong Bell's reflex, and I'm trying to control the eye with the cotton tip. I make my paracentesis incision on the right side and then the left side, making sure I'm parallel to iris plane, which creates a nice corneal shelf, which will allow me to achieve a self-sealing incision. This is intracameral epinephrine, and then some dispersive viscoelastic to coat the corneal endothelium and flatten the anterior capsule. I'm using the Orlock technique, which is twisting the incision with the cannula to turn the eye down. And this is a triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel, and then I enter. And I'm able to do this with great control because of the Orlock technique. You can see there's so much pooling, and so I decided I'm going to sop up all that pooling with a 4x4, and then I decided to use the Tegaderm hack using the back side of the Tegaderm with the paper and the writing on it. I'm just placing it right over the edge, and that paper will act as a wick to wick away any pooling of the BSS in this deep set orbit. So go ahead and start back over. I've made my incisions. Again, this is the Orlock technique. Twisting the cannula within the incision, turning it down, and this is the microrexus forceps, the sharp tips. I puncture the center, pull down towards me, nudge it to the right, grabbing the right side of the tear. You can see how wide the teeth of this forceps open. They are absolutely beautiful, and they're able to coapt so nicely. So I have excellent control, and it's just a very fine tip, refined tip. So I'm able to grasp it easily, the capsule, and going around, grabbing and re-grabbing the rexus flap. And with that Orlock technique with the cannula, I have excellent control, hopefully achieving a well-centered and sized rexus. Irrigating the surface of the eye, burping the incision, and then coating the corneal surface with the viscoelastic. This helps prevent my technician from having to keep putting BSS on the cornea. This is the capsule fornix hydrodissection technique. I place the cannula under the rexus edge contra-incisionally, wiggle the cannula, get a nice wave, lifting the lens up with the cannula, decompressing the bag, and as I decompress the bag, the lens begins to spin. Very important to get that separation of the lens from the capsular bag. Lifting the incision with the chopper, going in with irrigation off to minimize Descemet's trauma. You can see a very deep chamber. I'm sliding the chopper under the rexus edge contra-incisionally, turning the phaco tip vertically sub-incisionally, fracturing the lens in half. That's double chop. Sliding the chopper under the right heminucleus, hooking the peripheral lens, pulling it centrally toward the phaco tip, and fracturing the lens against the phaco tip like a chopping block. That is a cross chop. grabbing that first quadrant and fracturing the lens between the instruments and emulsifying the lens piece, turning that second quadrant in front of me, performing another cross-chop maneuver, fracturing the lens in half, and then using vacuum primarily, as well as some bursts of ultrasonic energy to remove that last piece. Turning the second heminucleus in front of me, sliding the chopper under the rexus edge, hooking the lens from the periphery, pulling it centered toward the phaco tip, fracturing the lens against the phaco tip, using some vacuum to grab the third quadrant, and then emulsifying it, loosening that last quadrant, bringing it up with the chopper, and then emulsifying it. Removing the epinucleus from anterior to posterior, very carefully prolapsing the epinucleus up. Again, shielding the posterior capsule with the chopper. Using vacuum very carefully, shielding the posterior capsule as I remove the last pieces. So I take the chopper out, push BSS in, take the phaco tip out, and I go in with the INA handpiece. Start subincisionally peeling from anterior to posterior, kind of doing a side-to-side wiggle to get nice big sheets. What a beautifully big pupil. You can see excellent visualization of the anatomy. Again, by peeling from anterior to posterior, this gives you the cleanest removal of the cortex. Switching to polish mode, polishing first the posterior capsule. You can see some of that lens fibers, polishing under the rexus edge. Polishing the posterior capsule as well. Pushing BSS to pulse into the subincisional capsule fornix. You can see there's a bunch of stuff that came out, switching to cortex mode and eating up those pieces. So again, very important to be able to clean the bag 360 degrees. You see some patients who've had cataract surgery and you'll see these dense Summerings rings. Really, with advanced techniques like we have now, there's really no excuse to have a Summerings ring after cataract surgery. A Summerings ring reflects incomplete removal of the cortex. And really, we have to do our best to make sure we get all of that stuff out of the eye, which is going to be the best for the patient. Using the sweeper to polish under the rexus edge, under the left side and then the right side. Removing the lens epithelial cells as best as I can. And this is the single piece acrylic lens. Injecting it within the capsular bag. Switching to IA, going in, activating irrigation, disengaging both haptics off the optic, getting underneath the optic, tilting it and rotating it 90 degrees, removing all the viscoelastic from within the bag, repositing the optic back down, polishing the rexus edge some more, removing all the viscoelastic from the anterior chamber, and then I will hydrate my incisions. So again, you can see this patient, deep set orbit. I put in the standard Lieberman. It seems so tight. I had very little exposure superiorly and inferiorly. And that's where the action is when you're doing cataract surgery with your second instrument. So I switched it to the narrow wire speculum. And you can see now, look at the exposure. It's so much better. I have excellent superior and inferior exposure, which is very important for temporal cataract surgery. And then I had all that pooling. You saw when I was making my incisions and so forth, there was so much pooling of BSS. Why? Because this patient has a deep set orbit. And because I had such good superior and inferior retraction, It did cause that pooling, and so I used the back side of the Tegaderm, the paper side with the letters on it. I was able to lay it on the temporal side, and that Tegaderm tape acts as a wick to allow that BSS to come out. So I was able to avoid any pooling of the BSS throughout the entire case. You saw very methodical and efficient double chop, cross chop mechanical fracturing techniques and concepts to very efficiently disassemble this lens, utilizing as little CDE as possible. And by doing the surgery this way in a very systematic and efficient way, and you're able to achieve excellent visual results post-op day 1 with clear corneas and happy patients. So I hope this was helpful to you, and I thank you for your attention.